Distinguished guests, fellows of the college, ladies and gentlemen, colleagues, friends. Cy Frank was a dear friend. He was a close colleague and well known to many of you assembled here today. I miss him dearly, and I think of him most every day. Here's a picture of him when he was starting medical school. Now, offering this legacy lecture represents an unparalleled and deeply personal honor for me, as you can imagine. To preface the presentation, I declare that my sole employer is the Cummings School of Medicine, University of Calgary, and I've had no conflicts of interest, but if anyone wants to pay me to have one, I wouldn't mind. I'm going to try to avoid using names today and connecting any successes to any individuals, as all of this work really has been done in teams. Research is a team sport. So too is healthcare. And of course, Cy Frank was the consummate team master. Here it was the day we started the OA team grant. I want to acknowledge and thank the sponsors of this legacy lecture, the Canadian Academy of Health Sciences, and I'm proud to be inducted. And Marty, after that first lecture, it makes me proud to be part of any academy where that's the lead talk. Thank you so much. Cummings School of Medicine, University of Calgary, and Alberta Innovates. May I start by recognizing Dr. Frank's family. He's two sons. Many of you don't know them, or both now, practicing surgeons. But most relevantly, please allow me to recognize his closest loved one, Helene Levesque, who's with us here today. She was with us last night. We're so glad that you were able to be with us today. So what do I want to talk about? And I'm going to frame this presentation. This is not really about a lot of science. Well, I think it is, the translation of it. I won't use many PowerPoints. And I have three things in mind. I want to talk about the healthcare system. So here's my outline slide. I want to address the healthcare system and those systems seeking to learn and improve, to achieve elevated levels of performance. And in so doing so, I'm going to offer you 12 characteristics of high-performing health systems. Secondly, and in turn, high performance really requires strategy, structures, processes. It doesn't happen by accident, and it needs to be configured within a learning system environment. And moreover, there is a real trajectory. There's a line of sight, actually, from innovation to research and to measurement to ultimately effective implementation of change in clinical policy and practice. So I'm going to use the strategic clinical networks in Alberta as exemplars of this line of sight. There's now 15 strategic clinical networks in Alberta. Some have been in place for 5 years, some are only a few months old, and there's something now to say about their outcomes, albeit I'm going to be highly selective in one of my choices. And finally, 3 issues in Canadian healthcare. I'd like to deal with 3 current day observations and suggest perhaps a few innovative solutions to what I consider vexing policy issues that we have still in Canadian healthcare. There's a lot, but here's 3 for me. Primary healthcare, waste, and affordability. So before starting, in essence, my agenda is, where do we need to go? Here's some examples of how you might choose to get there. And what are some of the outstanding issues we might want to be thinking about along the way? So before starting, let me talk about the strategic clinical networks. Before starting the networks in 2011, there was 3 international conferences held in Edmonton, and we invited in selected health systems from around the world, systems that were notable for high quality and their reputation. And Cy and I were charged with doing the meeting notes and summarizing the conferences. And perhaps one of my greatest personal regrets is we didn't go to distance and we didn't write it up and submit it for publication. Now I've adapted this list of 12 things that I think, and I've edited it, I've consolidated it, I've amplified a few, and I'm going to offer these 12 characteristics today as basically the thematic base for framing this talk. This 12, there's nothing important about my particular 12 in terms of others. They're not universally accepted. They're not necessarily exhaustive. And as you know, there's a heck of a lot that's been written in the last 10 years about learning health systems and high performance. So I'm going to go through these 12 characteristics, and then I'm going to present some STN exemplars, and I'm going to go back to the characteristics again and see how they might reasonably all hook together. So let me just really run through this list rather quickly. Number one, innovation and measurement are the foundations of learning health systems. Innovation points the way, and measurement tells us if we're getting there. The nucleus of this system is the patient and the public, surrounded by a responsive primary healthcare system. To achieve high performance as a healthcare system, you need to have some structures. There's got to be processes, and they have to be put in place to use best evidence and performance measurement if you want to achieve specified outcomes. Innovation engines in the form of clinical networks are well suited to drive change. And the patient voice must be heard and included like never before. Optimal care based on best evidence has to be codified into comprehensive clinical care pathways. That's how you know how to set up your measurement framework. And while these represent the standard of practice on average, care will always need to be individually customized or applied. That's particularly true for people with chronic diseases. High performance can't be achieved without comprehensive, longitudinal, person-specific health microdata, securely linked to an efficient, interoperable electronic record system. One person, one record. Strategies and processes for spreading and scaling innovations must be conceptualized and incorporated before the pilots start. Resource-hungry healthcare systems are going to have to find ways to underwrite innovation and change. It's no longer going to be possible to get this from new added resources. It's over, folks. We're into a zero-sum game. The incentive and the fuel for innovation is going to have to derive from rigorous measurement, capture waste reduction, and a payback model. Number 8 is what we need to do. Number 9 is how we need to do it. And a learning health system will need to use a meaningful proportion of their eligible revenues to underwrite targeted investments in research and innovation. And if you're going to do that, the impact of those research investments must be explicitly measured and of sufficient value to justify sustained investment. But when all is said and done, nothing is more important than this. If you want innovation and measurement to change policy and practice, top-down has got to meet bottom-up decision-making. And as I said to John yesterday, what a phenomenal day we had. But you know, you got to capture the hearts and minds of the prescribing antibiotic clinicians if you're going to change the practice. You can have national frameworks, you can have support from ministers, you can have money up your gazoo, but you better capture the hearts and minds of the clinicians whose behavior you are trying to influence. Now, I definitely don't want to do that. I'm going to go backwards, sorry, because I didn't do this properly. Randy, can you take me back to slide 6 while I'm chatting here? I want to tell you about the strategic clinical networks, if I might. Now, this work has been done or continues to be done with Cy Frank as one of the critical roles in it. And my approach here is really to go through a few exemplars with you in a moment and then relate those exemplars back to that list of 12 things. How do these things come about? But to tell you about the SCNs, remember, of course, that as Canada's first province-wide healthcare delivery system, Alberta Health Services was created in 2008. Remember now we have 4 provinces that have gone to a single healthcare delivery system. This is interesting, nice natural experiment. Hope we're watching it. So when Alberta Health Services was formed, there were a lot of problems, and to frame the solutions, frankly, we used the Donabedian model for quality improvement. Pretty straightforward. You got to deliberately set out to develop some structures. They got to have processes that are shown to work if you want to accomplish the outcomes. And the outcomes right here that we're aiming for, the triple aim: better health, better healthcare outcomes, best and maximum value for money. The triple aim has been our mantra. So in 2011, Alberta Health Services created 5 zones in the province. North, South, Central, Edmonton, Calgary, not surprising. Every one of those zones have unique population needs, for sure. And also just remember a little, Alberta has 3% of its population living in 50% of its land mass. So Alberta needed some evidence-informed provincial structures, some provincial processes that would add some balance to local area needs, to deal with clinical care gaps, to get better value for money. And to achieve this, the SCNs were introduced in June 2012 as the vehicle for supporting clinically led, evidence-informed change. And SCNs are focused on the triple aim, and they represent a very deliberate attempt to create top-down, bottom-up decision-making. And the leadership of AHS, to its credit, has provided the continuing support and resources to create this. Now, how do we run these? There's a dyad relationship. There's 2 people, senior provincial director, senior medical director, which take the lead, and every SCN is represented, proud of this, and Cy would be too. Every SCN has a scientific director with a deep research capability. And the job of the research director, of course, is to make the connections, develop the partnerships with academia, link us to SPORE, and what have you. Now, the leadership of the SCN, as I mentioned, these 3 people, the dyad and the scientific director, are complemented by a core multidisciplinary membership, a core committee. Core committee is about 30 or 35 people, and the core membership is a province-wide team of carefully chosen physicians, clinicians, strategy and admin leads, patients, government, and academic partners. And the core membership sets the priorities. They decide what's going to get done, they direct the plans, and they stimulate the activities. SCNs use existing data, and they use evidence to target the areas for improvement. We particularly look at clinical practice variation. We continually look at variations in outcomes. And so with operational support for the highest value initiatives, the SCNs use standardized and systematic clinical care pathways. That's the blueprint. That's the blueprint against which you set up your measurement framework to improve effective and sustainable care. And now, in each one of these, we have what we call PACERS. PACERS, P-A-C-E-R-S, patient advisors and community-engaged researchers. These are people that have had the experience of being a patient, but then they also agree to be trained in research. And the research training is provided over a year-long period, about 3 one-hour sessions every week for a year-long curriculum. It enables the group to have a greater capacity to participate. Remember, these are patients. There's currently about 40 of them. Wonderful, brilliant. And in a room, they change your conversation for sure. And we've got PACERs now involved as co-investigators on our research teams, participating in writing research grants, and the first few papers are starting to come out with our patient advisors and community-engaged researchers as co-authors. So now there's over 40 provincial projects going on now across Alberta and that are in progress, all trying to shoot for the triple aim. So let me choose 2, just 2 out of the 40. We have short on time, but I chose these 2 because I think they are fascinating. And remember, all of the 40 projects are aimed at provincial scaling, and these 2 have gone provincial scale some time ago. So the first example, stroke action plan. Stroke action plan. I've chosen this as an example of SCNs advancing evidence-based care, addressing disparities, making differences in outcomes. Now, if you compare the 5 zones in Alberta in 2010 in terms of 30-day in-hospital stroke mortality, 2010, wow, I was surprised to see that there was a difference of about 100 per thousand differences in death from the highest performing zone of the 5 to the lowest performing zone of the 5. 100 per thousand differences. That kind of variability in outcomes, demands attention. So the stroke action plan is a model of care designed to provide stroke unit equivalent care in rural and remote areas. How do we take it out to where the people are? The goal was to reduce morbidity, mortality, length of stay, and accelerate rehab, get better outcomes. So we enrolled 15 patient centers across Alberta. We implemented the new care model, and the results show 17% decrease in length of stay, 17 fewer patients per year going into long-term care, 88% achieved access to rehab within 48 hours. And in terms of stroke outcomes, 67% improved in activity limitation scale, 66 improved in impairment scale, complications dropped from 9 to 9.9%, and 30-day stroke mortality decreased. Stroke mortality, from 10.5 to 9.6%. Patient satisfaction climbed from 75 to 97%, and 3,377 patient days were saved from earlier planned discharge. Well, you know, this example really does have the potential to be scaled. It should be shared nationally. Other jurisdictions within Canada could be using Stroke Action Plan. Some already do use their own approach. So let's start saving the brains of Canadians that have had strokes. Second example is one of SCNs trying to address overuse of pharmaceuticals and inappropriate care. And this one is called appropriate use of antipsychotics in long-term care facilities. Now, the utilization of antipsychotics to manage the challenging behaviors of patients has been really increasing in Canada in the last decade. You know that. Antipsychotics really do increase adverse events, sudden death, agitation, confusion, falls, inability to communicate, what have you. You know, in comparative terms, Alberta had one of the highest uses of antipsychotics in people without psychosis in Canada in 2012. 26.8% of residents were on antipsychotics without a diagnosis of psychosis. 26.8%. One of the highest in the country. And one of the things that happened is, and one of the keys of the AUA project, was simply interprofessional medication reconciliation. One of the keys was simply sitting down and discussing the regular medication reviews of the patients and helping staff to find alternate ways to deal with patients. Music, exercise, art, supporting the families, and what have you. So 11 early adopter sites implemented AUA, and the program reduced inappropriate antipsychotic use by 50%. That means that of the 657 beds in which there was an impact, half of the patients were removed from antipsychotics over a 9-month period without any negative consequences. No more falls, no more elopement, no more nursing hours. So working in partnership with the SN, this is now being scaled and it's being spread. It's now being introduced to 14,000 long-term care beds in Alberta, 170 sites, and as of today, there's 1,000 fewer patients taking antipsychotics. And the CAHS data, I'm proud of, in 2015 showed that Alberta has the lowest rate of inappropriate antipsychotic use in the country, 17.4%. Remember, in 2012, we were one of the highest. So the team is now supporting work nationally. Canadian Foundation for Healthcare Improvement has picked this up. We're sharing the tools and techniques to spread and scale this to other sites in Canada. Everybody could easily be doing this. No charge. So let me come to part 3. There are too many outcomes from the SNs thus far to speak about any more than this, but I want to try to tie them back to this original list of 12, if I can, and make some comments as I move towards the final third. Well, key feature number 1, the no-brainer, innovation and measurement, shows the way and how to get there. Well, the Stroke Action Plan initiative was driven by evidence of unjustifiable variation in outcomes. You can't have in the same province that much difference in the outcomes without asking why and then trying to do something about it. And we were fortunate because Calgary had the best stroke outcomes in Calgary at the time, and this was far from true for other parts of the province like the northwest part of the province. And original research and innovative practices to support Stroke Action Plan came out of stroke research, funded by AHFMR, done in Calgary, done in Edmonton, and the medical schools. We didn't make it up. We just used what we had. The measurement that drove the processes and the practice included the no-brainers that you would expect: door-to-needle time, proportion of people to get on the rehab, how quickly, and then their clinical outcomes. And of course, what I might say, the latter factor, early onset physiotherapy in rural areas, has been truly the game changer in this one. It's improved the PROMs for patients, the clinical outcomes, and also the cost effectiveness. Well, what about key feature number 2? The nucleus is the patient and the public surrounded by responsive primary health care offered within the configuration of a medical home, embodied within a social contract, constructed on a foundation of trust, and informed by an electronic health record. I got to say that again. The nucleus is a responsive primary health care system offered within the configuration of a medical home, embodied within a social contract, constructed on the foundation of trust, informed by an electronic health record. Well, this has not happened in Alberta. Actually, it hasn't happened in Canada, with very few exceptions. And this is really the first of the 3 vexing issues I wanted to raise. Primary healthcare organization and practice is much the same now, today, in 2017, as when I was a family doctor in 1974. I'm sorry if there's family physicians or academics in family medicine in this audience, but tell me it's not true. Where's the organized, community-based governance for primary health care? Why have we been so slow to adapt and adopt the medical home philosophy? What's the social contract that each Canadian has with the system? What are we getting? We're all paying $6,500, $6,500, $6,500 each. What's the social contract? What would it be like if those with chronic disease were actual co-designers of their care and they managed themselves, like they do anyway, but now they were informed with self-measurement, self-management of their conditions supported by a primary health care system? What would that be like? We could spend a lot of hours on this and debate it till the cows come home, but to finalize at least on one point, on one positive note, let me at least say that about 2 months ago, we finally launched a primary and integrated healthcare SCM. 5 years of preparation and planning to get it done. Let me move to number 3. To achieve high performance as a healthcare system, you need structures, you need processes, drive it with evidence, drive it with performance measurement as a means of achieving outcomes. These innovation engines called networks. Well, there's a developing evidence-based arguing for the value of clinic networks in creating change and improving outcomes. A sound strategy aimed at high performance is how you start. You got to have a prerequisite. But success as a learning organization in achieving high performance has to include the clinicians. And they have to be in structural configurations. They have to use sound processes and be supplemented by healthcare decision-making support. And together with that, the patient voice has to be heard like never before. Not just informing them, not just involving them, you got to engage them. Like you're incorporating that voice in the co-design of your plans and in their care. The patient voice is inextricably connected to every one of our core committees and the working groups of SCNs. Our patients are not involved or informed, they're engaged, they're heard, and they have influence. In no place is this truer than the participation of seniors in the Seniors Health SCN. Now, polypharmacy in seniors really is a terrible, serious problem, and not just antipsychotics, and not just in long-term care, you know that. And now that we've had success, the program is now being extended this month into assisted living areas for seniors. And eventually, I'd like to see all mood-altering pharmaceuticals prescribed for seniors become the target of elder-friendly care. Like, why not? Why not? Number 5, toughie. Optimal care based on best evidence must be codified into comprehensive clinical care pathways. That's the measurement frameworks that come from those. And while these represent the standard of practice, everybody's an individual and you're going to have to adapt the care plan accordingly. No big surprise there. This is particularly true for those Canadians living with chronic diseases. I mean, you well know that over half of people age 65 now have at least one chronic disease. It's probably closer to 75%. And so, not to get off on that subject, but stay on the pathways. Let me just tell you about one pathway that's been the most operational for the longest period of time now, almost 5 years in the province. And that's hip and knee replacement. And I mention this because of Cy. You know he was an orthopedic surgeon, and he really believed in this one and work with the Bone and Joint Health SCN to make it happen. So there's about 10,000 hip and knee replacements every year in Alberta. And Alberta's orthopedic surgeons actually, they get together. They share performance data. They look at their report cards together. And they have access to the results anonymously compared to their colleagues. Hey, wow, that changes clinical practice behavior like nothing else. Now, if you applied the hip and knee clinical pathway over the last 5 years as we have, and it has resulted in really an impressive expansion in capacity. So we now do 79% greater surgical cases with 3% increase in beds. That's like 35,800 hospital bed days saved. Or if you wanted to turn into the money, 37.7 million saved by using the arthroplasty pathway. Waiting times are stable at 22.3 days from the decision to treat. Readmission rates are stable at 4.2. Patient satisfaction went from 89% in 2010 to 97% in 2015. Red cell transfusion rates, which really got the orthopedic surgeons' attention with their report cards, they went from 19.5% of cases now down to 6.3% and holding. They know now not to use red cells routinely. They don't order up 3, 4, 5 units of packed cells before to start the case. This has been a huge success in improving care and getting best value for money. Every place in Canada could be using the arthroplasty pathway adapted to your own context. Number 6, high performance cannot be achieved without comprehensive, longitudinal, person-specific health microdata within efficient, interoperable electronic health records. One person, one record. Well, we're kind of like with the U.S., scraping the bottom of the barrel on this one, believe it or not. You can blame it on InfoWay, blame it on the doctors, blame it on the vendors, blame it on their products. One person, one record? Don't think so. We're not there. Another one of those topics that could take hours, but I won't. And moreover, and as it relates to this topic, health microdata and data linkage for research purposes. 20 years ago, Canada was in the lead in this world. Now we're not. A few exceptions in the country, acknowledged. But wow, as the CAHS report of 2015 has shown, we have a considerable amount to do to achieve timely access to health information for research and practice. I'm getting behind here, and I know I'm pretty out of time. I'll try to speed, but I know I'm going fast already. Number 7, strategies and processes for spreading and scaling innovations must be conceptualized and incorporated before the pilots begin. I'm kind of tired of going and hearing other folks that I like a lot telling me that Canada is test case for pilots that never achieve anything. Well, hold on. Let's not dismiss pilots. How else are you supposed to know if something works? And then scale it up. But see, that's where the problem is, the scaling up. It's got to be conceptualized and incorporated before you start the pilot. So if you are ultimately going to be the place where we spread and scale this pilot, then you have got to come in and be involved with the design and the analysis and right through the process, and then it just actually becomes easy to spread it and scale it. Resource-hungry healthcare systems are going to have to find ways to underwrite innovation and change. It's not going to come from new and additional resources. I'll flip over that one because that's sort of the what, and perhaps spend a bit more on here the how. You need to be able to capture the waste, and you need to be able to turn that waste into resources that give you the headroom for innovation. You're not going to get any more money. So what do? You're going to have a really good waste reduction program that you monetize the savings, and you got to have a payback model. I mean, the premise is pretty straightforward. You can ask any clinician, where's the waste? They know. They know where the waste is. So you had to incent them and support them to get rid of that. And if the next year you reduce the budget, forget the engagement that follows. What we need is a type of payback model. Sinai, we're working on this one before his death. What proportion do we pay back? Who should get it? What's the distribution mechanism? And so on. But it's time. And nowhere in Canada have we done this at scale and got it such that we've got a payback model that incents clinicians to find a waste and get rid of it. That will work. Learning health systems need to make a meaningful portion of eligible revenues to underwrite eligible target investments in research and innovation. Psi helped with others to form PRIUS, the Partnership for Research, Innovation, and Health System. There's now about 30 projects aimed at the triple aim coming from PRIUS, $5 million a year coming from the funding agency and the health system. Health systems are going to have to invest more, and as they do, they're going to have to measure the impact. I can't spend time on it now because I know I'm out of time, but Paul Armstrong said to me yesterday, and I have to just comment that, remember, that was the first really expert panel, so I chaired it, and the CAHS framework is now widely used across the world. We use it now in CHR for the Institute for Health Service Policy Research. We use it for the National Center for Excellence in Frailty. We're just not using it enough, and we got to crank up research impact assessment, its methodology, and its approach, because we need to justify what we're doing. And in the end, nothing is more important than this, as I've already said. Can I take a minute to finalize? Okay, well, I said I would talk about 3 vexing subjects. Primary health care, I kind of did the drive-by shooting already. Waste, I've just mentioned. But let me just comment on affordability, if I might. You know, like, in virtually every year since Medicare started in 1971, growth in healthcare expenditures has exceeded CPI. Has exceeded CPI by 3, 4, 5, 6% every single year, but for 3. We've convinced ourselves that this is a worthy investment, despite everything we know about socioeconomic health determinants and the growing importance of investing in social care for chronic disease management. 6,500, 6,500, 6,500 each. That's what our system is costing us. And we're mediocre in quality, you know it. We're scraping the bottom of the barrel on a lot of the indicators in international comparisons. And we have to get control of cost. I believe that we have to have wage controls in healthcare, which is not going to come easy. Of course, the Ontario example recently has perhaps showed us that. But, you know, it's the largest proportion of cost in healthcare is the salary and benefits of the providers. I'm almost done. But yesterday someone sent me a slide. Oh my God, I couldn't resist. This is U.S. data. I'm not going to describe it to you. I just want to put it up because when I saw the slide, I was gobsmacked and I just wondered what the Canadian slide might look like. So let me move to conclude. I took your valuable time to talk about waste, primary health care, affordability, SCNs, 12 items that might be important. Why have I done that? Because Canadian healthcare needs more innovation. It needs to be connected with a line of sight to policy and practice. That requires a top-down, bottom-up approach. Not only is change possible, it's now mission critical. The Canadian healthcare system is not working too well, folks. And if you don't believe me, have you had a relative in the system lately? Because I have. And a 1 doesn't mean anything. But we got a lot of room for improvement in this system, folks. And we become complacent, our quality is mediocre, and we're bloated with waste. And there's a line of sight, you know, from research and innovation to implementation. There's a line of sight to improving outcomes to policy and practice. Canada needs to aim higher. We need to become a high-performing health system. And we can do it. There's no question it can be done. And my hope is that this lecture conveys that message, and the need for innovation and research has never been greater than it has been today, with implementable solutions for improvement. But you know, on this day, we should stop. We should pause. We should give thanks. For Cy Frank, 67 years of important and impactful results. Eternal peace to Cy. Thank you.